All right, here we are talking about the story of PT documentation. And this is going to play out quite a bit when it comes to both diagnostic processing, but also in patient care. Now, I call this a story because as you document, someone should be able to read your first note to your last note and see a very clear story with acts, scenes, all of those necessary components to tell where that patient started and where they ended. So the story starts with the subjective, and I would argue that the best way to get a clear start to your story is through the patient's eyes. So ask them, how can I help you, as opposed to tell me about your knee pain. And we're going to use knee for the example for this presentation. So how can I help you? As they answer that question, listen for measurable limitations in both activity and participation, and then look for clear patterns. These are all the patterns that you have been working to establish through your differential diagnosis compare and contrast charts. Recall that the purpose of the subjective is to give you a diagnostic set of hypotheses that are going to drive your objective testing. So an example of a response you may get from how can I help you would be, I'm having trouble going up and down stairs. It's a flight of stairs at work as well as at home, and it's because of some knee pain. And it's about a 6 out of 10 and usually kicks on by the second step. Now I understand that most times your patient is not going to give you this full, very clean, clear statement. They might simply start off by saying, yeah, I'm having some knee pain with going up and down a flight of stairs. Now, you started off with an open-ended question. Now follow up with a less open-ended question. Okay, can you be a little bit more specific with the flight of stairs? Can you give me information about what's going on and where it's happening? Then you might start to get this other information about it being a flight of stairs at work, which now gives you a possible participation limitation, and at home, which could be an activity limitation, in which that person is clearly describing limitations with being able to possibly go to meetings at work, as well as a limitation with possibly going up and down the stairs to access their bedroom or their office if it's on a different level than they need to be on. And then you can start moving more into close-ended questions, such as, where exactly is this pain? The front of my knee. And then if I gave you a scale of 0 to 10, where would you rate your pain? 6 out of 10. And how soon in that flight of stairs do the symptoms really start? Oh, probably the second step. And then how quickly do they go away when you stop doing the stairs? Pretty much immediately, of which this gives you not just a clear story, but also some information you need to help you determine how much testing you want to do. So now let's move into the objective. The objective, recall, is going to be driven by some of the questions you asked in the subjective, and it should continue to include all of the different differential hypotheses you created, as well as some possible medical systems that may require referral, and maybe a question mark. I like to have my students keep a question mark in their hypothesis list. That way they're always thinking, could this be something completely different than those that I've considered already? Now with the objective testing, I would argue one of the best things you can do is recreate that person's exact complaint with your testing. The reason for that is that validates your belief that load through the body is one of the reasons they're getting their pain complaint, or certain ways of moving their head or neck are related to their subjective complaint. If it's a dizziness, you want to have that person say, yes, this is what I'm feeling, because that means you can recreate it with what you do, which means there's a higher probability that it's amenable to physical therapy. Now, there are definitely times where that's not going to work. If the person has high irritability and high severity, you may not want to flare them up to prove that you can if they have a very robust, very clear-cut subjective background that points to one of your hypotheses. At that point, it's more important for you to decrease the symptoms and then maybe come back and recheck some of your other hypotheses with testing once you've got them out of that protection phase. Now, another case where you may have some problems with recreating symptoms are those people who have very low irritability and very low severity, because they might require a lot more load or a lot more repetition than what you're able to provide in the clinic. So there are times where you won't be able to do that or shouldn't do that, and that's where you need to make sure the rest of this person's subjective and objective story is very clear cut. That way you are safe to at least move them in the right direction and either test them later in the case of the high irritability, high severity, or ask them to reproduce their symptoms outside of the clinic doing whatever activity is. A prime example of that latter group with low irritability, low severity might be long distance runners that have to run 8-9 miles before they get their symptoms, and they want to be able to complete 10 miles or 15 miles. The other thing that the objective should have built into it is weighing and evaluation of relevant impairments. Recall that everybody has impairments. You need to start to look at impairments based off of your diagnosis as well as your treatment strategy. Now, when I talk about weighing impairments, don't just record impairments and start hitting them in a list. You want to have those impairments in front of you and then prioritized. So an example of this would be our anterior knee pain patient has a problem with going up and down stairs. You are doing your impairment testing. You see that they have 3- out of 5 strength for quadriceps, and they have 95 degrees of knee flexion that's limited by stiffness in the joint. I would argue that the more important impairment at this stage of the game for their functional and participation limitation of going up and down stairs is the quadricep weakness, not the range of motion limitation. Now, patients evolve as you work with them, so down the road they may start to say, I've also noticed that I have problems getting down to pick up my grandkid or pick up my child because my knee is so stiff now. I have to get them on a chair first and then pick them up. Well, now the goal has changed because they likely have completed or met the goal that you initially agreed to, which was the stairs. Now we have a new goal, which is getting into a squat position to pick up a child. And the weight of our impairments flip-flops. So now I need to focus more on that range of motion because the strength has resolved, or at least is closer to being resolved. So examples of how that subjective can drive forward your objective for anterior knee pain would be that person told me that they're younger in age. They told me that their symptoms are just proximal to the patella and are deep to the patella. So now I can start looking at internal derangement. If I'm thinking tibiofemoral joint, I might look at EGs. I might look at Thessaly's or McMurray's. If I'm thinking patellofemoral joint, I might look at the Noble test or the Grind test. If I'm thinking possible nerve, I might look at a femoral nerve slump test, which I am trying to assess for different hypotheses. Then my testing and impairment should support the diagnosis. If I think that this is a problem with a internal derangement of the patellofemoral joint, when I look at that person doing a squat, I should start to notice a possible medial collapse of the knee, which leads to higher weight bearing through the lateral epicondyle if I do indeed believe this is a nociceptive type pain. Now I have prognosis in there as well, because if I see this person has gross instability of their knee, that person likely has a weaker prognosis than somebody who has a relatively stable knee. Their medial collapse for that grossly unstable knee may be ligamentous based, as opposed to the stable knee, in which that medial collapse may be associated more with gluteal strength, which arguably responds to treatment, whereas laxity in ligaments does not. Now we move on to the assessment, and this is your chance to make a really good abridged summary of what you found as a subjective and objective, and give us a reason why this person belongs in your clinic and what you plan on doing with them. So the assessment statement should include things such as, things related to our compare and contrast charts for differential diagnosis or screening for medical referral. So epidemiological data, common subjective complaints consistent with that diagnosis, common objective findings consistent with that diagnosis. But you'll also need to include some prognostic statements relative to the goals that you've created or to the patient's goals. And I would argue that it's more important to look at the patient's goals. And then finally, for our purposes, we put the goals in the assessment section. So let's give you an example of a patient presentation statement relevant to the case we've already talked about. So this is a 34-year-old male who presents with signs and symptoms consistent with internal derangement, such as meniscal or cartilage injury or defect, has noted by pain with weight bearing, pain with terminal knee flexion, as well as special testing. Now, I didn't necessarily go into giving you the exact special tests, but you could do that, but I would limit that, or at least put in a statement that say, please refer to the objective testing. Now I move into why they need to be in physical therapy. They would benefit from intervention to increase range of motion and strength to decrease load on the affected structures during functional activity. So this is why do they need to see me again? Why am I here? And this is really how you tie in what you found and the reason for continuation. Some things that you should consider for the prognostic statement, which we don't go too much into with differential diagnosis coursework, but is the person's age. A lot of bad things have a higher prevalence as we get older. A lot of impairments also have a higher prevalence as we get older. So screening for medical referral as well as differential diagnosis comes into play a little bit more as we get older. We want to also look at the desired level of activity post-treatment, and I will add in relationship to pre-treatment as well as pre-symptoms. So pre-symptomology. So if the person has a desired level of activity and it's unrealistic based off their past, it's going to decrease their prognosis. An example would be somebody who comes into you because they have a knee injury and they were a couch potato, and they say that one of their post-treatment goals is to also be able to run a mile. Well, when's the last time they ran a mile? It's probably not going to be good for you to add in that as a goal, since you probably will move very quickly out of the physical therapy range or realm and move into more of a personal training realm, which is fine. Just realize that that's two different categories of intervention. Your prognosis should also consider comorbidities. A prime example would be an acute injury and diabetes. If it's uncontrolled diabetes, there's a fair chance that there is going to be a delay in healing, if not an actual cessation of healing. So that needs to be considered with prognosis. We also want to look at the current level of chronicity, in that if the person already has chronic widespread pain consistent with central sensitization, they probably don't have a good prognosis for becoming pain-free based off of everything we know from the research. Now, prognosis also looks at psychosocial factors. The psychofactors could be any negative affect. Negative affect would be anxiety, depression, rumination, these different features that psychologically drive physiological change, which could lead that person down a path of chronicity. The social factors also come into play in that if you know that their presentation will require daily home exercise participation, and they say that they've got a very busy life and they're not going to be able to do your home exercises, then their prognosis is not going to be very good because of that. Now this final bullet point is looking at prognosis. Should it or can it always be good and excellent? Now this is going to be a loaded question, but you've got two ways of looking at this. One is therapist-centric and one is patient-centric, of which you can possibly merge the two. So as a therapist, if you start to see a lot of negative prognostic factors and you want to make sure that you hit good and excellent, you would probably write extremely conservative goals that don't have much of a pain component if it's a pain presentation, because you have a higher likelihood of them actually meeting those goals, which means your prognosis is good or excellent. Now that's therapist-centric. Patient-centric would be just to write down whatever the goal is of the patient. So I want to be pain-free with going up and down stairs, yet they've had a persistent chronic pain for over 5 years. If you write they're going to be pain-free with going up and down stairs, their prognosis is definitely not going to be good or excellent because they have a false expectation. They've already reached a level of chronicity. It's not realistic. So I would argue that good communication and education and buy-in from the patient is going to help you meet in the middle. That way you're able to address some of their concerns. You're also able to help them understand how some of these other factors play into their outcome. And then you both agree to the goals. So the goals should be patient-centric. They should also be agreed to. I would argue very strongly they should be agreed to. And I understand this could create a very uncomfortable conversation on the front end for our more chronic persistent patients. However, it's much better to have it then when you're able to put everybody on the same starting page as opposed to get the end of the story and you say that you've met the goals and they say, I'm no different, because you haven't met their internalized goals. You haven't addressed their internalized goals. They didn't agree with the goals you started with. We also want to be specific with our goals. I don't want to see things such as a patient would be able to perform ADLs with 2 out of 10 pain or less. And the reason for that is that this doesn't help you out, and it definitely does not create a story. Saying ADLs, you can come in, the patient comes to see you. If you're in a high productivity-based clinic, how are you moving? They say, oh, I'm doing great. You think that they're doing fine, yet they haven't negotiated stairs in 2 weeks because it hurts, so they feel better because they haven't done what they want to do. The other side of the coin is they might come in and say, oh, I feel terrible. And you're like, oh, well, then the treatment's not doing well, so I need to change something. But you find out they feel terrible because instead of doing stairs, they ended up doing some other activity for 4 hours that involved going up and down stairs and doing a lot of walking, i.e. possibly going to, say, Disney World, which happens only once every 5 years for this patient. You might change your entire treatment plan under the assumption that they're talking about whatever the initial presenting complaint is, but you didn't record that and move that forward as a specific goal. So it's harder for you to come back to that very quickly when you get that check-in at the beginning of a follow-up. So try to be specific. So in this case, patient will be able to ascend and descend a full flight of stairs with pain of 2 out of 10 or less in 6 weeks. I've made this very specific, and I've also made it measurable, and it's patient-centric. Now, the plan for the evaluation, be specific with the plan. If there are items that you still want to test, either because you ran out of time, you think about them after the fact, or the person's irritability limited how much testing you could do that day, throw them in there. Say, I want to do this testing next time. You want to consider any progressions and regressions that you may have to do based off their response to treatment. Evaluation can create adverse events. Most of the time these are minor adverse events, but you want to be able to address those. You also may get the person respond very well to your initial treatment, and your initial progression was very conservative. You might need to bump that up next time. So have an idea of where you want to go. Meet them where they are, and then also be very specific to what your progressions are. Now, follow-up. Real quickly, we'll talk about the follow-up visits. So subjective should go back to the goal. So that goal was initially the patient problem statement. Prior to that, it was the subjective complaint that you opened the story with. So when they come back in, you want to start out your next chapter with the overall theme from the previous chapter. So check in on the subjective with the goal in specific and make it measurable relative to that goal. Objectively, you want to update their relevant impairments and reassessment signs. So remember, you weighed these, so you don't want to check impairments that are not the key focus point of treatment up to this point. You want to measure the ones that you have been focusing on. If they are now completely resolved, the patient has much better subjective ability, but they still have impairments and some problems. Now it's time to go back to your initial list and add in some of the impairments that you saw before that were not as important back then, but now are at the top of the list because you checked off previous ones. Assessment should be, where are they now? Where do they need to go? And why do they still need you? This is just, again, a nice abridged summary of the story up to this point. So an example would be the patient is responding to physical therapy focused on gluteal strengthening and patellar mobility as noted by improved symptoms with traversing stairs. He's still unable to traverse a full flight of stairs. This is likely due to some persistent strength deficits, which would have been measured in the objective section. I now say that continued PT is required to progress resistance training and improve kinetic movement throughout the lower extremity to further decrease pain with stairs. I have now justified why we need an additional chapter or another follow-up session. And then plan, be relevant and specific again. All right, guys, I hope this clarifies how we can use documentation to help you out with guiding your diagnostic process, your prognostic process, and your subsequent treatment and evaluations.